Hello, everyone. Welcome to this session. Let's start with pathology, hem-onc pathology. Okay, so the first thing we have is the acanthocytes. Acanthocytes are spur cells. We have the spurs coming out of them. They are associated with liver disease. Also beta lipoproteinemias, vitamin E deficiencies. We will see projections of varying size at the irregular intervals. So these are projections at irregular intervals. Acanthocytes are asymmetric. Then we have the echinocytes. They are the Burr cells. They, again, liver disease, ESRDs, and pyruvate kinase deficiencies. They are smaller and more uniform, and the projections, more uniform projections than the acanthocytes. Okay. Acanthocytes are even. Look, they're evenly large and more uniform than acanthocytes. Then the other ones, we have the dacrocytes. Dacrocytes are the teardrop cells. Look, the teardrop cells, they are seen in bone marrow infiltration. Example is myelofibrosis. RBCs sheds a tear because it's mechanically squeezed out of its home in the bone marrow. So it's mechanically squeezed out, so it tears, and seen in bone marrow infiltrations. Then we have the schistocytes. They are the helmet cells. Look at the helmet. And these are seen in MAHAs, microangiopathic hemolytic anemias. Example, DIC, TTP, and HUS. HELP syndrome, mechanical hemolysis. Example, in heart valve prosthesis. These are the fragmented RBCs. So schistocytes are fragmented RBCs. Then you have the degmacytes. They're the bite cells. There's a bite taken by the removal of the Heinz body by splenic macrophages. Macrophages take that bite and remove the Heinz bodies. They deg them out of, bite them off RBCs. That's the mnemonic. But they're seen in the G6PD deficiencies. Elliptocytes, longular, like elliptocytes. Ellipticals, hereditary elliptocytosis caused by mutation in genes encoding RBC membrane protein like spectrin. Okay, coming on to spherocytes. Spherocytes are seen in the hereditary spherocytosis, autoimmune hemolytic anemias. They are the small spherical cells without central pallor. Okay, and you have a decrease in area to volume ratio. And then you have the next one, which is the macrovalocytes. They are the megaloblastic. They are seen in megaloblastic anemia, macromegaloblastic anemia, and because of and also you also see hypersegmented multinuclear giant cells or multinuclear cells. Okay, that's the macrovalocytes. Now looking at target cell, look at the target sign, target cell. They are seen in Hep C, not Hep C, my bad guys, HBC disease, asplenia, liver disease, and thalassemias. HALT is the mnemonic for that. HALT set the hunter to his target. halt, set the hunter to his target. Again, this one also increases the surface area to volume ratio. And how do we have this increase in surface to area to volume ratio? Well, when you increase the surface area to the volume, you have some result. This results in redundant erythrocyte cell membrane, and that's going to fold upon itself, right? So that creates the formation of target cell appearance. Okay. And this is seen in asplenia because normally what's happening is the macrophages that are present in the red pulp of spleen, they remove the access membrane. This access membrane that we talked about, this is removed by the macrophages in the spleen. And this is a process called splenic conditioning. Splenic conditioning. But what happens after splenectomy, or you don't have a spleen, or if the spleen is not working, then this process is not working. So when this process is not working, you have the redundant membrane, RBC membrane, and that redundant membrane is going to fold on itself and have an appearance of target cell. Okay. That's pretty much it for the target cell. Let's talk about the next thing. What do we have? We have the sickle cells. Sickle cell anemia, sickling of the cell. Sickling occurs with low O2 conditions, like in high altitude and acidosis, high HbS concentration, like dehydrations. Okay, let's move on with the next thing. What do we have? RBC inclusions. In RBC, type we'll in bone marrow inclusions, which are the iron granules. They are associated with sideroblastic anemia, lead poisoning, myelodysplastic syndromes, and chronic alcohol overuse. And what are these iron granules? These are perinuclear mitochondria with excess iron, forming ring sideroblast. Okay, it requires Persian blue stain to be visualized. Persian blue stain. In the peripheral smear, you will have jolly bodies. They are associated with functional hyposplenia, example sickle cell disease, or asplenia. Again, these are basophilic nuclear remnants. They do not have iron. Usually removed by splenic macrophages, but when you have asplenia or not functional spleen, they cannot be removed by the macrophages or splenic macrophages, leading to formation of Hall-Joll bodies. Okay, then you have the basophilic stippling. Basophilic stippling is sideroblastic anemia seen in the sideroblastic anemia thalassemias. They are the basophilic. So what it is, it's a basophilic ribosomal precipitates, and they do not contain iron. So I think that what they're trying to say is they're mentioning iron a lot of times. So they really want us to know that you will have iron, and they will be called, again, look at the diseases here: sideroblastic anemia. Okay. And the rest of the diseases are something else. But again, in here they're mentioning sideroblastic anemia specifically, example like lead poisoning or myelodysplastic syndromes or due to chronic alcohol overuse. But they're mentioning in the bone marrow you will have iron granules. In the periphery you do not see any iron. So they're saying excess iron will be seen in known as iron granules in the bone marrow only. In the peripheral you don't have anything with the iron. Okay, but let's talk about one peripheral thing that has the iron, or maybe this guy also has iron, who knows. Yeah, so these two things have iron. We have the Pappenheimer bodies. They are again seen in the sideroblastic anemias. They are the basophilic granules, contains the iron. Pappenheimer, hammer is made of iron. Okay, hammer, iron. Then you have the Heinz bodies. Heinz body is seen in G6PD deficiencies. You have a denatured and precipitated hemoglobin contains iron, and phagocytic removal of Heinz bodies leads to bite cells. Again, you have a denatured precipitated hemoglobin that contains iron. Hemoglobin does contain an iron. So phagocytic removal of Heinz bodies leads to bite cell. If you were to remove this, you're going to have a bite cell. It requires supravital stain, very important, which is a crystal violet, to be visualized. So how can you visualize in G6PD deficiency? How can you visualize these Heinz bodies, which are basically the denatured precipitated hemoglobins? How can you visualize them? By doing a supravital stain. Supravital stain, and you will see these things in supravital stain. All right, moving on. What do we have?